All right, so good evening and welcome to another online lecture brought to you by the AMSSM Fellow Online Education Committee. I'm your moderator, Dr. Myro Lu, and our presenter tonight is Dr. Jeffrey Feden from Brown University. You see that our lecture is sponsored by the AMSSM Education and Fellowship Committee. The purpose of these lectures is to serve as an adjunct to your individual program's educational programming, provide fellows with direct access to educational experiences with AMSSM members and at times invited guest experts, and also to assist in CAQ exam preparation. As a reminder that if you haven't already, please mute your devices and turn off your video. After the program, please complete the evaluation, which will be sent at the end of the lecture. And please submit questions through the chat function, which if you want, you can include your name and the program if you wish, and we'll try to answer them throughout the presentation. So without further ado, I'd like to introduce tonight's speaker is Dr. Jeffrey Feden. Dr. Feden is an associate professor at the Alpert Medical School at Brown University. He is a graduate of Virginia Commonwealth University School of Medicine, and afterwards he completed a residency in emergency medicine as well as a fellowship in primary care sports medicine at the University of Pittsburgh Medical Center. He taught sideline emergencies at the latest AMSSM virtual conference and is here today to talk about anaphylaxis and severe asthma exacerbation. So Dr. Feden, thank you for being here today, and I'll stop sharing my screen and you can take over.
All right, thanks a lot, Myro. And thanks to Will, who's not here tonight, for the invitation. Thanks to you, Myro, for moderating here, and Andy for helping set us up and the communication here. So let me get on screen share. Okay. All right, you see my screen okay?
We see it. You see it okay?
All right. Here we go. All right, good. So so real quickly, yeah, thanks again for the introduction, Myro. I'm pretty much full-time in emergency medicine these days at Brown University in Providence, Rhode Island. That's our emergency department, big level 1 trauma center here for Southeastern New England on the bottom left. And then I work as a team physician, Bryant University, which is Division I school here locally. And then Roger Williams up there in your top left, team physician there as well, which is a Division III NCAA institution down in Bristol, Rhode Island, really pretty right on the water there. So that's my my sports medicine these days, in addition again to full-time practice in the emergency department. No disclosures to make. So first and foremost, why is this important to you? I mean, you guys are taking your time here on an evening to listen to this, so it's obviously important. I mean, I think you either are or are going to be team physicians, sideline physicians, event physicians. You recognize that anaphylaxis and severe asthma are serious conditions and can be really frightening conditions to treat. I got to be honest with you. Even for myself, an emergency physician trying to treat these conditions in the pre-hospital setting can be pretty anxiety provoking. And when they come in to the emergency department and they're really sick, it can also be, pretty stressful and anxiety provoking as well. So fortunately, these are rare occurrences. But again, that's why you're here, because these are things that you're not going to see on a regular basis. You're not going to see them on a weekly basis, necessarily even a monthly basis or an annual basis. You may see some of these things every, several years. And so it's all the more reason to kind of think about it and be in tune to it, so that when you are presented with a clinical condition like this that is life-threatening, that you are able to act and know what to do and know how to handle it. And you don't want your athletes to die at the end of the day, right? That's worst case scenario, worst possible outcome. So you want to be able to prevent these sorts of things. So we have a few objectives. I mean, first and foremost, the charge here was to kind of look over some basic pathophys and clinical presentation, and then acute management of anaphylaxis and severe asthma exacerbation. So we're not going to get into a lot of the chronic stuff. We're going to focus more on the emergency management. I took the liberty on the front end to just put a little bit of information in terms of the primary survey, assessing the collapsed or acutely or critically ill athlete or patient, being able to recognize life-threatening conditions in the pre-hospital setting, and then providing life-saving treatment. And then on the back end, just wanted to make mention of the importance of emergency action planning when you're talking about life-threatening conditions. That's really an important piece of it. So I took the liberty to add that in at the end as well. So those are kind of my stated objectives. Here are the take-home messages. I'm going to give you this right up front. So if you want to log off and eat dinner, then feel free. This is what you need to know and what you want to know. So again, how does this impact you? This really impacts you, I think, in terms of as sports medicine fellows or sports medicine providers, in terms of your athletic coverage, when you're on the sidelines, when you're at the finish line of a race or another event, or when you're treating patients in a variety of settings with known pre-existing conditions such as asthma and anaphylaxis. So the key here, of course, as it is in many things, is early recognition and action, and to be able to anticipate the clinical course. Anticipation is so important, that you not only recognize, but you anticipate, what can be the clinical severity of these conditions and how patients can deteriorate quite rapidly. So just having that level of awareness and anticipation, I can't overstate. Anaphylaxis and asthma are unpredictable entities. And again, prompt recognition and treatment, because you really sometimes can't predict very well the course, for better or for worse. You don't know who might get better, who might deteriorate very quickly. And the unpredictable nature of these conditions makes them that much more frightening. And fatal anaphylaxis and fatal asthma are often considered to be preventable, given the right intervention. So you really want to just be prepared. And that includes emergency action plans at an institutional level, individual action plans with your patients, with your athletes, including education of your patients, and making sure they're fully understanding their condition and the potential consequences of their condition. And then we'll talk a little bit at the end. I have one slide just on mental rehearsal or cognitive rehearsal, and how you can use that, again, when you encounter these infrequently encountered conditions in your sports medicine practice. So that's the take home. So imagine this. So let's just take a few seconds. I want you just to kind of pause and reflect and think. Let's consider that you are on the sidelines, and let's say it's football, and you have an athlete that comes out of the locker room before the game and comes up to you, it's the team doctor, and says, "Hey doc, I got a little scratch in my throat, maybe a little rash or a little itch on the arms." And you look at that, and you look at the athlete, and I just want you to think, and maybe the athlete has known allergies, maybe not, maybe you know the athlete well, maybe you don't, but just with that, those kind of relatively innocuous symptoms, I want you just to take a few seconds and think about how you would approach that and what you would do. And I'll pause to let you think about that for a moment. And now imagine that athlete, over the ensuing minutes, starts to get a little short of breath. Maybe gets so short of breath as to have some noisy breathing, maybe some stridor, kind of a game changer here. So, think about that as time passes and as the condition progresses. Think about how you might handle that now and how you're equipped to handle a clinical scenario like that in the pre-hospital setting, with whatever resources you may or may not have. So then I pose this question: ultimately, are you prepared for this? And if you're not prepared, how can you prepare? How can you be prepared to handle what is potentially a life-threatening emergency outside the hospital, on the athletic field, on the sidelines? What can you do to make sure that when this presents to you, which it may never, but likely you'll see at some point in your careers, something that is potentially catastrophic, on the field of play. And so how can you be prepared for that? So A, conveniently for this talk, is for anaphylaxis and asthma, but A also is for airway. And like I mentioned before, A is for anticipate. Okay, so that's really key here. Let's talk a little bit about the basic approach to an acutely ill athlete or maybe a collapsed athlete. So the clinical presentation of a critically ill athlete can be many things, including mental status change, noisy breathing, unable to speak, respiratory distress. And so, we in emergency medicine kind of learn on day one the primary survey or the ABCs. Most of you, I'm sure, are familiar with this. It stands for airway, breathing, and circulation. And this is the way that we approach in a very systematic way, in a very quick way, we approach any life-threatening conditions. And as we approach those conditions with attention to airway first, then you want to generally consider treating the threat to life. We're taught not to kind of move on, into the next case, into the next letter until we have adequately addressed any life threats. So without an airway, a patient cannot survive, obviously, and so the airway is paramount. Breathing and circulation come subsequent. So A is for airway. In sports medicine, of course, this includes C-spine immobilization when indicated. So if there's a concern for C-spine injury or trauma, then C-spine immobilization occurs at this point as well. You want not to manipulate the airway or do anything like that without attention to the C-spine when necessary. And then there's, then it becomes really a focused clinical assessment for airway compromise. So what are you looking for here? You're looking for, audible noises, inability to swallow, it's a sensation of throat swelling. You may not have actual physical exam changes or findings, but just a sensation of throat swelling and then changes in the voice as well can suggest impending airway compromise. So when you think about conditions that cause airway compromise, of course, anaphylaxis is amongst them. An unresponsive athlete can have a compromised airway for simple reason of having a tongue obstruction. The tongue kind of falls back in the airway, that can obstruct. Infections, any kind of oropharyngeal infections can cause airway compromise. Of course, foreign body, an aspirated foreign body, and blunt trauma to the neck, an expanding hematoma, or a laryngotracheal injury. These are some probably the most scary airway related problems you can encounter, especially in the pre-hospital setting and the hospital. And so once you have kind of assessed the airway and considered conditions that might cause airway compromise, then you have to think about what your airway management equipment and techniques are. We're not going to go into that. It's beyond the scope of this lecture. We do this in the SMART workshop. And so I guess that's a plug for the SMART workshop in April. But you're probably not going to have too much in the way of airway management equipment and techniques, with you on the sidelines. Breathing. So we move on to breathing. And so, these are things like cyanosis, inability to speak in full sentences, and then confusion or agitation, coupled with respiratory rate that's either high or low. You get a respiratory rate into the 30s or 40s. It's very concerning, of course. And then abnormal lung sounds if you have the ability to auscultate the lungs. Again, here in terms of, in the pre-hospital setting, basic diagnostic tools and interventions, you probably don't have too much. You may have a pulse oximeter. If you have EMS available, perhaps you have supplemental oxygen, but otherwise you're not going to have too much here, in terms of breathing. And then you move on to circulation. And so you're looking for signs of poor perfusion, pallor, diaphoresis, delayed capillary refill, tachycardia, hypotension. And again, you're not going to have, too many tools in your tool bag on the sidelines necessarily. So you're going to, maybe find ways to position the patient, put them in a Trendelenburg position where you put their head down and their feet up, as long as they're protecting their airway to increase their venous return. And then, maybe you have some access to IV supplies and fluids. So just kind of basic approach again to the collapsed or acutely ill athlete keeps it very systematic in terms of how you look at that. So anaphylaxis. So what's anaphylaxis? Anaphylaxis is an allergic or hypersensitivity reaction. It's generally rapid in onset and it's potentially fatal. The estimated lifetime prevalence from all causes is quite low, up to 2%. So I'd say 2% is relatively common. Presentation, of course, may be fairly variable and sometimes atypical, so it can be kind of challenging to recognize. I'm going to give you the take-homes for anaphylaxis right up front. So anaphylaxis is generally a clinical diagnosis. You're not going to have any diagnostic tools that are going to help you here. This is really clinical. Anaphylaxis, as we mentioned, can be highly unpredictable. And so you need to recognize that and appreciate that. Death can occur literally within minutes. So, it can be really scary to deal with this. And early administration of epinephrine is critical. And I would imagine that most of you know this already, but again, it can't be overstated that epinephrine is critical in the treatment of anaphylaxis. And it's critical that it is done early. So what's the clinical presentation of anaphylaxis? I think most people associate skin and mucosal symptoms such as hives, itching, flushing, or pharyngeal swelling, angioedema, for example, periorbital edema. That usually occurs in about 90% of cases. Respiratory symptoms also very common, maybe in up to 85% of cases. This is nasal congestion, discharge, sneezing, kind of the itchy, scratchy throat, sensation of throat closure, voice changes, stridor, shortness of breath, wheezing, cough. So lots of different respiratory symptoms there. And then GI symptoms, of course, nausea, vomiting, diarrhea, cramping. Cardiovascular symptoms include syncope, collapse, dizziness, tachycardia, hypotension. And again, rapid onset of symptoms in terms of the clinical presentation here, which may occur really in seconds or minutes. So how about the diagnosis for anaphylaxis? So there are actually diagnostic criteria. And it's important to recognize that anaphylaxis really represents a whole clinical spectrum, as do a lot of conditions. So here are the diagnostic criteria. You're probably not going to have this, readily at hand when you're trying to make this diagnosis, when you have somebody with potential anaphylaxis in front of you. But we'll look through them real quickly. So criteria number 1, this is involvement of greater than or equal to 2 of 4 organ systems below after an exposure to a likely allergen for that patient, of course, with acute onset. And then when we look at the organ systems, as we mentioned, skin, mucous membranes, respiratory, both very common, and then gastrointestinal and cardiovascular. So at least two of those with a likely allergen exposure for the patient. Criteria number 2, hypotension after exposure to a known allergen. So patient has a known allergy and exposure, and they have hypotension. That in and of itself is criteria for making a diagnosis of anaphylaxis. If you look at adults, this is just a systolic blood pressure less than 90 or more than 30% decrease from their baseline. You may not know their baseline, so you're looking, generally at a blood pressure less than 90. Criteria number 3, 1 or both of the following plus acute onset of, skin or mucous membrane involvement. And then in addition to either respiratory symptoms and or cardiovascular involvement. So if you have skin findings and you have respiratory symptoms, that would qualify as anaphylaxis. Skin, mucous membrane findings, plus some sort of cardiovascular involvement. And it doesn't have to be hypotension. It can be dizziness or syncope or something of that nature. So, sensitivity is good, specificity less so, from a paper in 2016 here. And it's important to remember that, again, you're not going to have these necessarily in front of you to reference. And so you have to be somewhat familiar, but just have a really low suspicion and threshold to treat. And, even if somebody falls outside of these diagnostic criteria, it may still be warranted to administer epinephrine to that patient. Okay, so keep that in mind. You may not kind of have the specific criteria met, but you still may want to give epinephrine because it is so important and can be life-saving. So pitfalls in the diagnosis of anaphylaxis: over-reliance on hypotension and shock. I think a lot of people think about anaphylaxis as a shock syndrome. And so, if there's no shock, then it's not anaphylaxis, but that is not true. Hypotension and shock, as you just saw, are not absolutely required for diagnosis. Skin findings, we said, are very common, 90%, but 10% they may be absent. So you may not have the classic urticaria, or itching or flushing or those sorts of things that accompany anaphylaxis. Anaphylaxis may be mistaken for asthma, so that's pitfall. And then the first episode, may be difficult to characterize. So if you have an athlete, that has anaphylaxis and has a known exposure, well, that's hopefully pretty easy. But if it's a first episode, you may really have a harder time making that connection. The pathophysiology of anaphylaxis is one of a multi-system syndrome. Again, as you saw, many different organ systems affected, and then involves generally a sudden release of mast cell, basophil, or macrophage-derived mediators. So there are kind of two varieties here. One is immunologic. So this is IgE mediated, and this is an immune globulin mediated release of inflammatory markers such as histamine and tryptase. And then the non-immunologic variety, where you just have massive mast cell or basophil degranulation. This is not immune globulin mediated. And really the end organ effects that we worry about, first and foremost, are cardiovascular and respiratory. This is where, advanced or end stage anaphylaxis, fatal anaphylaxis, you worry about cardiovascular collapse and respiratory failure. And so, the effects here in the heart are to depress myocardial function, myocardial ischemia, and it can be arrhythmogenic. And then from a respiratory standpoint, bronchospasm, mucus plugging, and laryngeal edema are the big concerns. So the treatment. So it's generally understood that anaphylaxis is most responsive to treatment early. You look at fatal anaphylaxis, and these are often cases where, for whatever reason, epinephrine administration has been delayed. And so there seems to be a pretty clear connection between, success in treating anaphylaxis with early treatment. So it's epi, right? This is the treatment. Again, even if diagnostic criteria are not met, epi is pretty low risk intervention. It's the mainstay of treatment. So this epi, there's no substitute, and it really best addresses the pathophysiology of anaphylaxis, as we just mentioned. Most patients, will respond to a single dose, but some will not. And so some people will require repeated dosing. As we mentioned, failure to administer early epinephrine has been associated with fatal anaphylaxis. So this is something you want to do, pretty immediately. There are really no absolute contraindications. So I think some people may fear epinephrine in those with cardiovascular disease, kind of unfounded concerns for the most part. When you're administering epi, particularly in, an IM intramuscular format, then you really don't have to worry about effects on the cardiovascular system. If you're giving it intravenously, maybe a little bit different, but that's typically done in the hospital. Intravenous dosing can be more often associated with dosing errors and things of that nature. But you're concerned about effects on the heart, but remember that anaphylaxis has the heart as an end organ. An end organ effect on cardiovascular system. So, you probably don't need to worry about that, practically speaking. This is going to be given as an intramuscular injection into the mid-lateral thigh. The dose is weight-based, maximum of 0.5 milligrams. The auto injectors are 0.3 milligrams. And again, you can repeat this at 5 to 10 minute intervals. So up to a third of patients, 20%, 30% of patients, it said, may require a second dose after about 5 or 10 minutes if there hasn't been appropriate improvement in symptoms after the first injection. And really, in conjunction with administering epi, once you're doing that, you probably want to activate 911 and get some help and get the patient to the hospital if you're doing this in the pre-hospital setting. So those, administering epi and activating 911 should probably be done in parallel. All right. I wanted to pull up this video. I don't know. I guess I can't assume that everybody is familiar with how to use an auto injector or that you've ever done it. And so this is just a brief video, about a minute, that just kind of walks you through it. Pretty straightforward, but you need to be kind of mindful of the orientation, removal of the safety cap, and those sorts of things. So I'll play this for you real quick.
How to use Epipen on someone else. If your child or someone you know has severe allergies, it's important that you learn how to use Epipen correctly. That way, you can feel more confident and prepared in the event of a severe allergic reaction. In the case of an allergic emergency, every second counts. That's why Epipen should be used at the first sign or symptom of a severe allergic reaction. Just follow these 2 simple steps. Grasp the Epipen autoinjector with the orange tip pointing downward. Blue to the sky. Remove the blue safety cap by pulling straight up. Do not bend or twist it. Orange to the thigh. Place the orange tip against the middle of their outer thigh. Swing and push the orange tip firmly into their mid-outer thigh until you hear a click, and hold on their thigh for 3 seconds. Count slowly. 1, 2, 3. Epipen will work through clothing if necessary. After Epipen is used, The orange needle cover will automatically extend to cover the needle. This safely covers the needle as the autoinjector is pulled away from the thigh. You will not see the needle before, during, or after use. The extended orange needle cover and black indicator in this window will show you that Epipen has delivered its epinephrine. Remember that using Epipen does not replace seeing a doctor or going.
Okay, so just kind of a quick little tutorial if you've never done it. And again, remember you can use it right through clothing. So seconds matter. Again, I mean, how do I know this is anaphylaxis? Should I treat it? There's really little room for debating this in your head. I mean, if there's a concern, Epi is very low. IM Epi is very low risk and is well tolerated, and so you want to probably just go ahead and treat it if there's any question. Time from onset of symptoms. This paper in 2000 by Pumphrey looked at fatal cases of or cases of cardiac arrest related to anaphylaxis, and the time from onset of symptoms to cardiac arrest, in like IV medication was 5 minutes. Insect stings, 15 minutes, food exposure, 30 minutes. So really, I mean, seconds count, minutes clearly count, and you spend too much time contemplating, then that can have really poor consequences for your patient. In terms of adjunctive treatment, so, IV fluids, oxygen, positioning, if the patient's protecting their airway, you can lay them down and elevate the legs to increase venous return. IV epinephrine, as we mentioned, should be used with caution. You're probably not doing this except in a hospital setting in the emergency department, for example. And then adjunctive treatment. So classically, we'll give antihistamines, glucocorticoids, et cetera. Really, Epi, is the treatment. And so diphenhydramine will offer symptom control for hives and itching, similar to the H2 antihistamines like famotidine, symptom relief. Glucocorticoids, we do this pretty frequently, but there's very little evidence, maybe a benefit in asthmatics, but there's very little evidence for this. And then bronchodilators can be used for bronchospasm, but are not protective. We're treating airway edema. That is a real concern for airway obstruction and compromise. And so they're not going to get you a lot of mileage either. I'll just show you kind of a little video here real quick as well.
I think you have food allergies.
Oh.
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 Wow.
What?
Benadryl? Where's the Benadryl?
Aisle 2.
Which one's out 2?
The one with the big 2 over it.
Sarah, I'm fine.
You sure it's in out 2?
No.
Really, it is not that serious.
Benadryl. A lot of Benadryl. A lot of Benadryl.
What? Oh! Oh! Whoa! Oh, whoa! Whoa! Can't kill some shark. Death on a leaf! Come on!
All right, so pretty classic, anaphylaxis there perhaps, and going for the Benadryl, which I just told you is not the thing to do. So epinephrine is what he wants there in that clip from Hitch. So I thought that was kind of comical, but spreading misinformation. So additional considerations for anaphylaxis. So it's important to recognize the potential for biphasic reaction. And so this is, an asymptomatic period after the initial episode, followed by recurrence without any further allergen exposure. The asymptomatic interval can be anywhere between 1 and 48 hours. So this can occur sometime after the initial episode, but with a median time probably of around 11 to 12 hours. And this is thought to occur probably with about a 5% rate. But also some evidence to show that when it does happen, that second episode is sometimes clinically insignificant. So won't necessarily be as severe or problematic as the first. Follow-up care, after an episode of anaphylaxis, a comprehensive history to try and identify inciting factors and those sorts of things is important. Being able to try and confirm the diagnosis and cause, which can be really difficult, assessing risk factors such as asthma. and then oftentimes a referral to an allergist. Although, if you're like me here in Rhode Island, we have very few allergists, and so it can be really challenging to get somebody in to follow up with an allergist. But that's kind of generally your move on the outpatient side, and then you go from there for different testing options and determining treatment, whether it be immunotherapy, desensitization, those sorts of things. Patient education then becomes really important. Even if there's an identifiable trigger, avoidance is of course essential, but just education around symptoms, treatment, injection with the auto injector of epinephrine, those sorts of things the patient understands, because there are going to be accidental exposures, and you can't avoid stinging insects and things of that nature. Just a few words on exercise-induced anaphylaxis, because it's a sports medicine group. So it's pretty rare, but anaphylaxis may occur only in association with exercise, and it can occur at any time during exercise or following exercise. As the exercise progresses, the symptoms will progress, and then cessation of exercise generally allows for recovery and improvement. More commonly has been associated with really vigorous activities, and it's rarely fatal. There is a subtype basically that is food dependent and exercise induced, where there are certain food triggers then in combination with exercise will produce anaphylaxis, which is pretty fascinating. And then diagnosis for exercise-induced anaphylaxis generally kind of follows the course of an exercise challenge test. So you exercise somebody, put them on a treadmill, for example, and see if they develop symptoms. Laboratory studies, there's talk about this. I don't have any clinical experience with this. I mean, you can test tryptase levels within an hour or two of the onset of symptoms, and then retest again 24 hours later to get a baseline, and you look for changes in levels from the baseline. But my understanding is there's pretty limited value here, because you can have normal levels and still have anaphylaxis, so they're not particularly helpful in every case. So again, anaphylaxis is a clinical diagnosis. Anaphylaxis can be really unpredictable. Death can occur very rapidly, and early administration of epinephrine is critical. That's what you need to know. All right, I'll pause just for a moment for any questions. Myro, if you have any questions in the chat or anything like that.
Dr. Feden, no questions in the chat, but one question on the exercise-induced anaphylaxis. Just clinically, what do you think as far as the typical timing to get someone from an event like that into testing and then return back to sport?
Yeah, I mean, I think if you're looking at exercise-induced anaphylaxis, I don't know that there's any kind of clear protocol. I mean, I think for that sort of thing, because it's exercise-induced, you probably need to go through some testing and have a kind of a more formalized action plan for that, and feel pretty comfortable that you've done your due diligence to go through the paces there before you get somebody back to exercise. So I think you probably have to be a little more cautious with that, of course, than you do with just general anaphylaxis due to other causes. In those cases, it's again kind of individualized, but generally, with the patient that has recovered and is feeling better, again, you still want to have, I think, an action plan in place, but can probably get those athletes back to play a little bit more quickly, if that makes sense.
No, that's good. And there's one other question. This is from Ahmed, and he asked, if anaphylaxis is misdiagnosed and epinephrine is administered, what are some side effects to look out for?
Yeah, I don't think, I mean, you're probably not going to have with just the IM injection, you're probably not really going to have much of anything. Maybe you get some palpitations or things of that nature, but you're probably not going to have really any side effects. I mean, it's a low dose and it's very well tolerated, and so you probably wouldn't know the difference. That's the thing, there's this stigma, I think, around using and injecting epinephrine. It seems like a dangerous thing, and people worry about the cardiac effects, which are probably not relevant in these cases where you're treating with IM dose of epi. If you're giving IV, that's a different story, and so that's generally being done in the hospital with monitoring, and the opportunity for dosing errors and things like that is much greater. And again, probably some greater potential effects on cardiovascular system. But I don't really think you're gonna see much, especially in the young athletic population, that you're gonna see any real adverse effects from a single IM dose of epi. So that's why it's really, I think, a low threshold just to use it when there's any uncertainty.
No, that's good. So again, like you said, just make sure epi, and it's better to shoot the epi instead of wait and see if they are having anaphylaxis if you're concerned.
Yeah.
How about if there's a biphasic anaphylactic reaction, and since the second episode is often very mild, is there any benefit to prophylactic antihistamine? And then my second question, that was from one of the viewers, but I would also say in your setting in the ER, like if they come in after they're administered an EpiPen, how long do you normally wait, or how long do you monitor them in the ER setting before you send them home?
Yeah, good question. I mean, I get, it depends on the clinical course, obviously. In terms of monitoring, we'll usually keep people for like 4 to 6 hours is the standard. I think 4 hours is what's generally accepted. I mean, if you look at the time frame generally is 12 hours, mean. So we're not keeping them for that long. In certain cases, maybe if it was a little bit more of a protracted case or something of that nature, we may keep them longer. But typically they're going to go home around 4 hours, and they're going to get really strict precautions. They're going to hopefully have an EpiPen and those sorts of things in case they had any issue at home. But yeah, we're going to usually let them go home at about 4 hours or so. In terms of kind of prophylactic treatment or treating them, we are generally, again, in the emergency department, kind of standard practices to have them go home and continue on diphenhydramine. We often give them a couple of days of prednisone for whatever that's worth. It's obviously not evidence based. I told you that steroids really are not shown to have any benefit in anaphylaxis. So I think it makes us feel better than the patient. But I mean, I think there is generally some anticipatory guidance that way in terms of at least, some Benadryl or something of that nature to maybe help reduce any symptoms that may be lingering or, prevent any recurrence. But it's all soft. It's, pretty soft in terms of the evidence base.
Gotcha. And then we also have one more question about like EpiPens and again, the cost of the EpiPens. And having them expire. Are there any other recommendations because of the cost for sideline med kits as far as like epi vials with needles? What are your thoughts on that?
Yeah, so boy, the auto injector is the best way to go. I mean, you could have a vial and stuff. It gets a little more difficult in terms of trying to dose it. If you're not familiar with that. So I would stick with the auto injector, I think is the most practical way to go. I don't know what the cost is. I know the cost spiked up, but that's been several years. And I believe they've come back down. And so I don't know that the cost is really as prohibitive as it was there several years ago. So, I don't think that's an issue. It's interesting in terms of the expiration. Most medications, I think, have a shelf life of probably about 3 years. Epinephrine, my understanding is that it's about 18 months. They put a shorter shelf life on those, but somebody actually, I can't recall the study off the top of my head, but I know that somebody looked at this and they looked at basically, active concentration of active medication in an EpiPen, and it was something like out to 4 years. You still had you may have had a decrease in concentration, but still generally felt to be effective doses in an EpiPen. So, I think ideally you probably want to replace it around the date of expiration, but if for whatever reason you can't, and this was an issue when EpiPens were very expensive, was that, you could probably safely keep them beyond the expiration date, beyond the shelf life, and use them effectively. And if you have no other options, it is still better than nothing. So, rather than throw it away, you're better off to have something. But you probably have several years of viability in an EpiPen beyond its, even beyond its expiration date.
No, I agree. And I would just kind of also add that with epinephrine, if you are having vials and needles, you got to make sure you have the right concentration, because with EpiPens, they're 1 to 1,000 and the cardiac is 1 to 10,000. So again, like you said, there's some confusion sometimes with drawing up different concentrations and how much you actually give to get that right dose per their kilogram. So again, I agree. Just having the EpiPens is probably the best. But other than that, that was the last question on the anaphylaxis. So Flores,
I will just add, remember too that the dosing route is intramuscular. So, we're not giving this sub-Q. It's much more bioavailable in an intramuscular dose than it is subcutaneous. And again, you're not going to be doing this IV outside the hospital.
Yep.
All right.
No further questions right now.
Okay, good. All right, so let's we have just a brief time on asthma here, and then we'll try and wrap up. So A is also for asthma. So asthma, kind of defined by the global initiative for asthma is a heterogeneous disease. Things we kind of know: chronic airway inflammation defined by the history of respiratory symptoms, wheezing, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitations. So, if you look epidemiologically, that's kind of a hard diagnosis to use. And so more often we'll look at current asthma, which is simply bronchial hyperresponsiveness in the presence of wheezing in the previous 12 months. And when you look at that, that definition epidemiologically, the US prevalence data shows about 25 million cases of asthma. That's about 8% of the population. There has been, a variable mortality and whatnot over the years, but a general decline recently in mortality. Interestingly, in the UK, for I think a 10-year period closing in 2018, a paper that showed an increase in mortality over that time period, but they also felt that about 2/3 of those deaths were avoidable in terms of patients not having a regular review of care, proper, instruction on proper inhaler use, or written action plan. So again, kind of very preventable in terms of fatal asthma. So here are the take homes for asthma. So similar to anaphylaxis, so severe asthma exacerbation is life-threatening. Asthma also can be somewhat unpredictable. We generally tend to think of it as being more predictable, and most of the time it is, but for no clear reason, sometimes you can have patients that have mild or moderate asthma that can progress to life-threatening severe asthma exacerbation. So similar to anaphylaxis, early recognition and treatment are critical. And then, when we talk about the ABCs, you're going to skip A, because asthma, while it may seem like an airway problem, is not an upper airway problem. It's more of a respiratory or breathing problem. And this is where you're going to really focus your efforts on oxygen and especially bronchodilators early and often. So clinical presentation of severe asthma exacerbation. Early recognition and treatment is the best strategy. So getting out ahead of it, knowing your athletes, knowing your asthmatics that you're working with on a regular basis, and understanding their history of asthma, what they're using to control their asthma, how frequently they're flaring, those sorts of things. Signs of severe asthma exacerbation, which are, not always universally present in life-threatening asthma, interestingly, but you look for things like tachypnea, respiratory rate in the 30s, tachycardia, in the 120s or above, accessory muscle use, inability to speak in full sentences, things that you're probably generally familiar with. Cyanosis, mental status changes are really ominous findings. So those are potentially late findings and really worrisome. If you want to look at objective things, you can look at a peak flow. Peak flow is not an exact science, but generally speaking, for an adult, less than 200 liters per minute would be characteristic of severe asthma exacerbation, or less than 50% or so of predicted, if you know what the patient's predicted is or their previous. Hypoxemia, when you get SATs less than 90, that's kind of worrisome. And then also, you just need to remember to consider alternative diagnoses. You consider anaphylaxis, even pneumothorax, if there's any history of chest trauma, or spontaneous pneumothorax if a patient has severe dyspnea. Then those are other things that you just need to think about. So you don't want to kind of zero in on asthma all the time. You want to kind of keep a broad differential, basically. In terms of acute management, so really the objective here is to reverse airflow limitations and then correct the hypoxemia and hypercapnia. Hypercapnia being a later finding, as well as somebody tires out and starts to retain. So supplemental oxygen is kind of an easy and initial treatment option. And then really we look to the inhaled short-acting beta-2 agonists, albuterol, for example. In terms of dosing for this, it's generally going to be, a neb is 2.5 milligrams. So 2.5 to 5 milligrams every 20 minutes or so for 3 doses, or in some cases, patients, in the emergency department will put them on continuous albuterol, 10 or 15 milligrams over that first hour. Alternatively, you can use an MDI with spacer, and you can administer 4 to 8 puffs as opposed to nebulized albuterol. Interesting systematic review of 700 plus patients looking at outcomes related to MDI with spacer versus neb found little difference. And then, it's generally considered that about 4 to 6 puffs from an MDI is equivalent to a nebulizer treatment. When they're in the emergency department, at least pre-COVID, we were, all these patients are getting nebs. It's just kind of easier to administer, but you're also losing a lot of medication. So if you have somebody that is, carefully using an MDI with a spacer, then you can get, equivalent effect from 4 to 6 puffs. So that's important to recognize. So not everybody needs, I was talking to an athlete the other day who was having a little bit of asthma, and he's going to be traveling And he was, he wanted an inhaler and wanted to take his nebulizer machine. And I, kind of instructed him that it's pretty much the same thing to use his inhaler as long as he's using a spacer with it as taking a neb. But people feel like nebs give them more medication to deliver better. For moderate to severe asthma, ipratropium is recommended, a short-acting muscarinic antagonist. Generally for severe asthma, but it can be hard to distinguish sometimes moderate from severe asthma. And so this would be recommended treatment. Again, like albuterol, it can be nebulized or used with an MDI with a spacer. And then when you look at combination therapy, really kind of variable results on peak flow and forced expiratory volume, but did show some reduction in hospitalization. There were maybe some increased adverse effects in terms of tremor, palpitations, those sorts of things. But again, generally recommended for moderate to severe asthma exacerbations to offer combination in conjunction with the short-acting beta-2 agonists. Systemic glucocorticoids, so doesn't really work for anaphylaxis, but really important for severe asthma. And you want to give it early because the clinical effect can take several hours. So it's not your first and foremost priority in asthma. But the earlier you get it in, the earlier it's going to work, basically. So there are associated increased rates of improvement with glucocorticoids. It's interesting. The optimal dosing is not really entirely clear in terms of, do I give 60 milligrams, 80 milligrams of methylprednisolone, 125 milligrams. You probably don't need to go with the massive doses around 500 milligrams of methylprednisolone, for example. But generally speaking, it's kind of variable in terms of which doses you use. Oral prednisone is often given around 40 to 60 milligrams. The oral and IV are really comparable. Oral has excellent bioavailability, and you get peak serum levels at 1 hour, even with oral prednisone. You don't want to give it IM. IM has much slower onset out to 24 hours. So oral or IV are best and are comparable. Mag sulfate. So mag sulfate is also generally recommended for severe asthma exacerbation or life-threatening asthma at usually a single dose of 2 grams IV. You can redose it, but a single dose of 2 grams is generally recommended in severe asthma exacerbation. It does have some degree probably of bronchodilator activity, and some studies will say that there's generally little benefit over beta agonists and whatnot, but magnesium sulfate has an excellent safety profile where you really are not going to cause much harm by giving it. So especially in the sickest of the sick patients. And then epinephrine, occasionally we'll use epinephrine for severe asthma. And so kind of not clear that there's a lot of added benefit there, but it may have some benefit in reducing airway edema and adding a little bit of a beta agonist effect. And so, kind of jury's out, but relatively harmless again to give that as an intramuscular dose as we've discussed. So just a few words on fatal asthma. So, as I mentioned, fatal asthma can occur across the spectrum of disease severity and is related to severe airway obstruction. And so when I say it occurs across the spectrum of disease severity, you can have mild asthmatics that can have fatal asthma. When we look at fatal asthma, there are kind of two different kind of temporal relationships. One is relatively slow onset, that's more common. And this is often in those with poorly controlled disease that deteriorate over time. So, most of these cases are symptoms that are going on beyond 12 hours or for several days or sometimes, weeks, where they're kind of just generally declining and not being treated appropriately or seeking care. And this is kind of the classic eosinophilic inflammation, airway obstruction from desquamation of the epithelium and mucus plugging. Rapid onset of asthma is, again, about 20% of cases. And so this is less than 2 to 6 hours from onset, so much quicker. And this is related to bronchospasm of smooth muscle. There is, for those with rapid onset asthma, there are reports from patients of NSAID sensitivity, and so that may be in some way related. It's not clear. And then also in these cases, it can be difficult to distinguish from anaphylaxis. So in a rapid onset case, you need to consider anaphylaxis as well. And so this may be a case where epinephrine is an appropriate treatment, even more as a first line in addition to bronchodilators. So you can kind of get a sense of, who the at-risk individuals are. Those with generally poorly controlled asthma, you can inquire about hospital visits within the past year, how often they're using glucocorticoids orally. And then, of course, any history of near fatal asthma. So those that have been intubated or in the ICU are clearly at risk. And then there are a lot of different minor factors that, are maybe less significant, but can maybe confer some sort of risk. This is sensitivity to aeroallergens, pet owners, for example, food allergies, respiratory viruses, smoking, vaping. Exercise in and of itself is relatively uncommon trigger for fatal asthma. There was one paper that looked at a number of cases and found that this was more likely to be in those between 10 and 20 years old, more specifically 10 to 14 years of age, and were more commonly associated with basketball and track for some reason. If you look at objective measures for at-risk individuals, those generally with a low forced expiratory volume, and just those that have a poor perception of dyspnea for whatever reason, they have a harder time kind of perceiving, sensing, and then communicating their levels of shortness of breath. And then, as we've already mentioned, fatal asthma is often preventable. So patient education action planning is really important here. 80% of the cases are slow onset, and these are people who are not receiving the appropriate care or medical attention for hours, days with their asthma, and kind of gradually declining. So they can often be prevented. Just a kind of a quick mention, I thought it was important to put this in there. Not all that wheezes is asthma. So remember, there are asthma mimics out there. And so just in talking to athletes, and particularly when you're going back to the pre-participation evaluation and getting histories and understanding asthma histories and whatnot, there are things that mimic asthma, such as inducible laryngeal obstruction, or what we typically have called vocal cord dysfunction previously, can be mistaken for severe asthma. And this can be kind of scary in terms of how these patients get short of breath, and can be really exacerbated or triggered by exercise. So this is, involuntary closure of the vocal cords during inspiration, and can result in shortness of breath, wheezing, and cough, particularly in response to exercise, but also may occur alongside asthma. So some of these folks have asthma as well. A bunch of other asthma mimics here: COPD, sarcoid, cardiac disease, and those sorts of things. And then exercise-induced bronchoconstriction. I mean, we're doing PPEs, and can't tell you how many athletes, have been diagnosed with exercise-induced asthma, or more appropriately called exercise-induced bronchoconstriction. And so we know this is bronchoconstriction during or immediately after exercise. Exercise is, clearly a trigger in those with pre-existing asthma. But, some of these folks really, you have to really determine that they do have asthma or documented asthma, because there are also a lot of other causes of exercise-related shortness of breath in athletes that we need to just kind of be in tune with. So we won't go through all those, but just kind of some important considerations. So asthma, again, the take-home points: severe asthma exacerbation is life-threatening. Makes sense. Asthma can be a bit unpredictable, as can anaphylaxis. Early recognition and treatment are critical. And then this is where you're going to kind of move beyond A, because this is less of an airway or less of an upper airway issue as it is a breathing problem. And so oxygen and bronchodilators are your mainstays of treatment to start. So very quickly, emergency action planning. I think it's hard to have a discussion about life-threatening conditions and not just mention emergency action plans. So having a comprehensive, detailed plan for catastrophic events is essential, right? So catastrophic events, similar to asthma and anaphylaxis, can be unpredictable, right? We don't really know when these things are going to happen. We hope they never happen. But of course they do, and we want to be prepared. So management of these sorts of things is essential, having some sort of a coordinated plan. So an emergency action plan is essentially that blueprint for handling emergencies, which includes education and training, maintenance of emergency equipment and supplies, appropriate use of resources and personnel, formation and then implementation of a very organized and structured approach. It should be comprehensive. Should be practical. It should also be kind of flexible so that it can be adapted to different circumstances, and it should be really generally very easy to understand, because lots of people are going to be looking at this and trying to kind of implement this, carry this out. So, and it just provides some accountability. So it establishes accountability for different parties, whether it be team physician, administrators, coaches, EMS, kind of runs the gamut. So, you can look at emergency action plans at the institutional level, and then you can also specify emergency action plans at the individual level for those with both asthma and anaphylaxis. So, obviously an ounce of prevention. So it really starts with the PPE. So, if you can understand the history of your athletes and kind of know their past, that will help to obviously prevent issues down the road. So recognition of these conditions obviously hinges on knowledge of pre-existing condition. And then, for anaphylaxis, for example, it doesn't project very well, but on the left, this is from one of the organizations, and basically just speaks to details of previous history, understanding, recognizing all allergies and known triggers. For athletes and patients to recognize reactions, and then a clear understanding of the need to administer epi, as we've really hammered home tonight. Making sure athletes and staff even, in your athletic settings know where the EpiPens are stored, how to use them. And the staff are really instrumental here too. So it's, the athlete should know, the athletic trainers should know, anybody that's working with that athlete in a sports medicine setting should know, where the EpiPens are, who needs an EpiPen, who's got a history of anaphylaxis at a very basic level, so that there can be a coordinated response and a clear understanding from the team when action needs to occur. Similarly, this is from NHLBI. So this is an asthma action plan and just kind of laid out for the athlete, kind of where they stand in terms of their symptoms in green, yellow, or red, and what the different action steps are for them based on where they are, and kind of talks about some danger signs and things like that. So, just kind of keeping people kind of in check and making sure that they are really understanding well where they stand in the spectrum of disease severity, and can kind of act accordingly. So we'll finish up. So mental rehearsal. So I like this concept because high level stress can impair performance. We kind of know that. There's been some research that shows that mental practice or rehearsal leads to improvement in team-based skills, versus just kind of traditional training, from this paper in 2015. And I think, whether it kind of is borne out in the literature or not, I think it's a valuable tool for just preparing yourself for stressful situations or skills that you really infrequently encounter in clinical practice. Again, these are things that you're going to deal with on an extremely infrequent basis, fortunately. But when they happen, they really demand an incredible sense of urgency to potentially save a patient's life. And so, I would encourage you to kind of think through these scenarios. If you have opportunities for simulation, that's great. But if not, just think through these things in your head, when you're driving to an athletic event, when you're going on Friday night to a football game to be on the sidelines, think about your approach to an athlete that is collapsed on the field, to an athlete that, comes off of the field short of breath and wheezing. Think through these things so that when they actually do happen, then you at least have rehearsed in your head, and you can kind of be prepared somewhat to take appropriate action. Know where your equipment is, what your resources are, know what the critical actions are. They're pretty simple in terms of what we've discussed here tonight with asthma and anaphylaxis. It's an EpiPen and it's an albuterol inhaler, basically. So know where those resources are, the equipment, and those sorts of things, and how to deliver. So the take-home messages, again, as I mentioned earlier. So how does this impact you? So if you're covering events, you're covering sports, this has got to be top of mind. And then your athletes with known pre-existing conditions, you should be having conversations with them ideally, and understanding their history and making sure they're educated on their condition. Early recognition and action, anticipate the clinical course. So they may not look too bad to start, but you need to be able to anticipate that this is somebody, particularly with anaphylaxis, that this is somebody that can really deteriorate pretty quickly. And so that's why when you administer epi, you're going to be calling 911 so you can get them to the hospital, so you're not delaying further treatment and potentially, compromising their health and sometimes leading to fatal anaphylaxis or asthma. Very unpredictable. Prompt recognition treatment are essential, often preventable, and then just be prepared. Emergency action plans, individual action plans, educate your patients, mentally rehearse. And so again, kind of think back to that athlete that kind of, comes up to you and maybe has a little bit of an itch in his throat, has a little bit of a rash, and, then potentially progresses on to shortness of breath, and just think about how you would approach that in a systematic way with ABCs, and then, you know, the importance of just kind of trying to act and do something where minutes matter. Great quote that I often use, attributed to a bunch of different people, maybe Benjamin Franklin, but by failing to prepare, you're preparing to fail. So, I mean, a lot of this, you know, a lot of dealing with these catastrophic events in sports medicine is just being prepared, as you already know. And that's really key, because, you know, it's just, they're just so infrequent. And if you encounter it on a day-to-day basis, no big thing. But when you're seeing this stuff so rarely, you've just got to be prepared to jump into action when the time calls. So that's all I have for you. I'm happy to take some more questions about any of that. But I appreciate you being here tonight. I appreciate your attention. Hopefully that was helpful, gave you some practical information, and maybe got you prepared a little bit for the boards as well.
Dr. Feden, that was a great lecture. Thank you very much. There were 2 questions for follow-up. One was on this is going back to the exercise-induced anaphylaxis. And they said on CAQ, some scenarios recommend inhaled cromolyn along with albuterol for exercise-induced anaphylaxis. Is that still recommended?
That's a good question, Myro. Honestly, I'd have to go back and look at it specifically too. You know, I'm not 100% certain. So I'm happy if, you know, whoever asked that wants to shoot me an email, we can kind of check it out. But I mean, I know there is kind of a role potentially for some prophylactic type treatment, but the details, I got to admit, I'm not entirely certain.
Good. And then last question was, again, this may be a little out of scope, but again, in the time of COVID, in your experience in the ER, have you noted athletes who have been diagnosed with COVID are at risk for more asthma exacerbations during gameplay?
No, and you know, I believe there is some literature on that there is not a kind of clear association with COVID and kind of increasing asthma exacerbations, is my understanding. So that kind of relative risk, so far as I know, is not clearly borne out.
Gotcha. Well, thank you, Dr. Feden. I think that was the last question that we had here, and I think we're right at that hour point. So thank you. I'd like to thank you again for such a great lecture and the conversation throughout. Again, for the viewers, I just kind of want to remind you also that the next lecture will be on Monday, November 22nd, because that is the Thanksgiving week. And the topic is going to be ankle and foot dislocations with Dr. Joseph Park. So again, thank you everybody for tuning in. And again, if you can go ahead and fill out any evaluation that's sent out from Andy Meyer, that'd be great. And thank you, Andy, for helping out with all this.
Myro, there was a request for my email address there. I'm just putting it in the chat so that if you want to just keep it open for just a second, then people can grab it. And then if you need to get in touch with me, please feel free to shoot me an email.
Okay. I see that there. Thank you very much.
All right. Take care, everybody. Thanks again for being here tonight. Appreciate your time.